Hi, my name is Diane. I'm a board certified psychiatric nurse. I'm also board certified in holistic nursing, and I'm here to train you on mental health training for caregivers in Florida. This is part 2. There's 3 hours of training, and it's divided into 6 parts. This is part 2, understanding mental health treatment options in long-term care and assisted living. So the purpose of part 2, we only have a half an hour to pack in a lot of information. So for patients to receive optimal care and outcomes, there's a great need for training on multiple levels in addition to available treatments. So there's a lot of barriers to mental health treatment, and I think we went over some of them to build a base coat in the first session. There's a lot of stigmatizing beliefs, and everybody thinks not me, but we all have our own reactions. I consider the staff as a healing environment, the nurse, the home health aide, everyone that interacts with somebody in crisis or stressed can be a healing environment, and they can also be a not so healing environment. And lots of times how you become a not healing environment is when you yourself have stigmas or biases that you don't even understand that you have. So part of our work and our journey is to improve our own individual and the staff's ability to recognize cognitive decline and the possibility of effective treatment. So a lot of people that we have in assisted living and long-term care, they may have cognitive decline such as Alzheimer's or other types of dementia. And lots of people say, well, what are you going to do? There's nothing to do, but there's a lot to do. There are so many things that you can do to optimize your patient's life and perform or provide person-centered care, and getting rid of that one stigma or bias that nothing can be done. You can't cure it, but you can certainly optimize their life. You can recognize medication side effects as being a part of decline. There's a lot of things that you can do if you just widen your perspective and become a detective of sorts, and open your heart and your mind to the possibility that you could give better care. So recognizing that staff response and awareness of signs of mental stress can greatly improve patient outcomes. And how we do that is that we intervene earlier. When I think that it would be safe to say that people are their patterns, success leaves clues and so does failure. And when someone usually doesn't act out in a vacuum, they certainly don't act out without an antecedent most times. An antecedent is something that may increase the stress or cause stress. You can have setting events or antecedents to behaviors. And when someone is aware that maybe increased noise, hunger, menstrual cycles in a younger patient, pain, visiting hours, all of these things can increase the stress and then make other mental health issues, depression, anxiety, confusion, more. So you have to kind of be aware that there are some things that you can do. So also the recognition of pending mental health exacerbation can reduce staff and patient injury. I mean, we all come to work. We want to do good work. We want to get paid for our work. We want to be safe. We want to keep our coworkers safe. And we also want to work in an environment that is respected and valued in the community. And when you do good work, and you're happy and your patients are happy and your fellow coworkers are happy, the facility is happy. So it's like the gift that keeps on giving. How do we do that? By doing things in a timely manner, by understanding the symptoms of mental health illness, and what we can do and what we can't do to optimize the outcomes. So the goal of all facilities is to create a person-centered culture, and the first goal of the caregiver is to see that person through a person-centered lens as a human being and not the bipolar manic in room 13. And I would think in all these years that I have been a mental health nurse that we're better at not labeling people, but we're not as good as we could be. It should always be one of our goals, and self-awareness is key. So part 2, objectives. On completion, you should be able to identify social and emotional contributors to worsening mental health with age. And remember, you could have younger people too, but you can't go over everything in a half an hour. But if I could plant seeds of awareness that you would identify patterns or open the door in your mind to possibility, then my job would be done. List patient barriers to effective mental health care access. List provider barriers to effective healthcare access. Identify ways frontline workers can provide person-centered care and how that contributes to improved mental health. And identify different types of treatment modalities used in mental health. So everybody that comes through your door, even if they've been seen by providers, doesn't mean they got the correct care. They could be overtreated, they could be undertreated, they could have received no care at all, or not so good care. So our job is not to say, well, they have a doctor, and if the person, let's say for example, a person is presenting severely depressed, and you look through their medications and you're like, well, they're on Prozac, and so it stops there. That would be a bias, or in your own mind, or in your clinical mind, or your clinical expertise, that one pill may be enough to solve this person's issues. So you're always looking, yeah, they are being treated, but maybe I should report it to the nurse, like, hey, they're on this, and, Mrs. Lilly says, this Prozac, my pink pill, always worked for me, but lately I've been really blue, and I've been not being able to do some things. And maybe she had some self-awareness and shared that with you, and you can just float on up the line to the appropriate provider that maybe they can change something for her. So just because you see a treatment that matches a diagnosis doesn't mean that it's doing exactly or what it should be doing. Is it effective? And is there anything else we can do? So there's just some statistics for mental health, and I went over some of them in part 1. There's a lot of people with acute mental illness, and any mental illness. And like we had talked about in section 1, that DSM-5, which is this huge volume of mental health diagnoses and their associated symptoms. You have to meet criteria to be diagnosed with anything. But we're trying to, in this very short training, to identify that people are their patterns. Stress exacerbates any kind of mental illness, really, how to recognize patterns of stress, how to alleviate them, and how to report accurately the symptoms that you're seeing so the person can get good care. So as people age, of course, problems become more intense, more acute, more visible, and it's really not, it should not come as any surprise that someone who may have had struggled with some mental illness, coped fairly well throughout their life, really decompensate when they become elderly for multiple reasons. Loss of identity coming into placement, loss of their home, their dog could have died, they could be a widow, they could be having cognitive decline, exacerbated by pain, amputee, they have congestive heart failure, they're on a handful of medications that have side effects of anxiety and depression. So as we age, our bodies fail us in many ways, and the treatment for a lot of those ways can make mental illness worse just by side effects. Many challenges. So mental health treatment is everyone's responsibility. When we're working with a person and we're treating them in person-centered care, we have to remember that it is our responsibility. And I really think that the person, the frontline worker, is in the position to impact the most change in someone's life, either by recognizing, supporting, elevating concerns to the appropriate provider up the line, recognizing changes in pattern. Your job is just absolutely essential. And if you do it brilliantly, you can really change people's lives. So, so the person-centered care, staff training on mental illness, and accurate observation and reporting of patient symptoms is essential. So I gave some examples here about maybe when we just label people, we are shortchanging them and we're not being respectful, and we're also not addressing their symptoms. Just because someone has a mental health diagnosis doesn't mean that their behavioral symptoms or their complaints aren't valid. So you always have to look at, like, you might have a delusional patient, but somebody really might be stealing their stuff. So keep an open mind. Okay, so we've talked about you being an essential member, a home health aide or a frontline worker being an essential member of the team. You're like, well, I'm not a psychiatrist, what would I know? But like we had talked about in part 1, people are either remember there was an 11-year gap between the onset of symptoms and actual seeking treatment in a lot of cases. Well, what if their symptoms started when they were 60 and they entered the assisted living at age 68 and they never got treatment? So sometimes people, or maybe they kind of covered or masked or really weren't really noticed by anyone before until they've reached a group living situation. So they may come to you with a mental health diagnosis that's undiagnosed. And also, anyone that comes into placement really should be assessed for depressive symptoms in the first several months for all of those reasons that we talked before. We talked about, the grief, the loss, losing your sense of identity, not being employed, kind of the end of the road for you, compressing all of your belongings in one room, maybe sharing with a roommate. It's a difficult time. You cannot take away people's pain, but you can certainly help or recognize or support them. And I do believe that even the happiest of persons could become depressed when they first come into placement. So let's talk about, so why do healthcare providers impede care? Aversion such as stigma. So let's say you had a really difficult bipolar patient in room 16 and you're like, not today, no, my kid vomited all morning, I was up all night, I really cannot deal with this woman today. But the only other people that are on the shift are new people that never dealt with her at all. They're like, so is it fair or ethical to say, not dealing with her? You would tend to avoid someone, maybe put them more at risk for somebody and your coworkers at risk for not, if they didn't know the patient and they were traditionally very difficult. I do think that in order for you to see patterns, you have to know your patient. If somebody is very difficult or challenging and you find yourself avoiding that room, then perhaps you're never going to be able to use your skills, your clinical skills, to help that person. So another reason is the tendency to focus solely on psychiatric symptoms and miss comorbid medical issues. Let's say, there are so many times I've been a psychiatric nurse for a long time. I worked home health and I would go in and they'd be like, she is just so confused. It's ridiculous. And she would be sitting there and I'm like, well, how long was she confused? And they said, about a week. They have Alzheimer's, that's what happens. And I'm like, well, maybe we should just, see what's going on with her. Even though they might have been slightly confused before, this massive change in cognition really didn't seem to be the normal trajectory for the progression of disease, So we would send them out, and lots of times they were dehydrated, which is huge in worsening symptoms, or had a urinary tract infection, or they started a new medication and were having side effects of medication delirium. So there were so many things. Maybe if they were just sitting in a corner somewhere, they're like, well, she's always confused. And so you always try to look at the patterns, like she wasn't like this yesterday, she's like this today. She could have had a stroke. So your job is not to say, what are you going to do? But really to look at patterns and say, well, you know what, she is confused, but this is different. And like make sure that you represent that to someone that can do something about it. So lots of times another issue is the failure of mental health and substance abuse treatment providers to screen for other conditions as well. And then lots of times the way we impede care is that maybe they don't tell people about their illnesses. And I think that the stigma is a lot less now. I've been a mental health nurse for like 25 years. And when I first started, and I was working with people that were in their 80s, and they were very proud, and they did not talk about mental illness. It was just very painful for them to disclose it, and they had to be extraordinarily in bad conditions where it was unbearable for them to seek treatment. So I think that now it's a little better, but I still think that there's an element, whether culture, be it culture or religion or personal philosophy, that they may not seek. It may be hugely embarrassing or difficult for the family or the patient to accept a mental illness. So the patient, poor patients are notorious for treatment fidelity. Fidelity means that you're doing what you say you're going to do. Lots of medications have side effects, particularly antipsychotics, so they don't want to feel bad. Sometimes they have, or even like cardiac pills have a side effect of impotence, so they don't really want to take their blood pressure pill and then the blood pressure pill may increase different symptoms. So it's hard. A good relationship with your patients might be able to tease out some of the nuances. Maybe they could get them a different one. You don't want your blood pressure to go sky high, but you also don't want the people lying and saying that they're taking them and they're not. In order to really be compliant with a lot of issues, it requires lifestyle changes, and a lot of people aren't willing to do that. Most of us aren't. It's very, very difficult. Lots of people self-medicate. I often think like a lot of people with alcohol abuse issues or substance abuse issues have an underlying mental health problem. Not always, but sometimes people are self-medicating. The old adage, drowning your sorrows or numbing yourself out. It's a very painful world, and people historically have not been trained or to really tolerate pain very well. None of us have. I don't know if there is a training for that, but the best we can do is to have support and acceptance, but we really don't have a way to deal with the pain of just living your life and living it for a very long time, as these people have. So for this reason, it's every healthcare worker's job to be knowledgeable about basic symptoms and report observations to a supervisor who can elevate the concerns up the line. And to be aware that they may come to your facility without a diagnosis or without ever having treatment and be in complete denial. So if you understand what the symptoms of anxiety are, if you understand what the symptoms of depression or confusion or delirium or dementia, then you're in a better position to serve your patient. So basic types of mental health treatment, there's lots of things now, but basically psychotropics are prescription medications that affect how the brain works and cause a change. They cause changes in mood, awareness, thoughts, feelings, and behaviors. Things like antidepressants, anxiolytics, anti-anxiety pills, antipsychotics. The psychotropics are medication designed for mental health disorders. There are lots of things that may contribute to depression or whatever, but those aren't psychotropics like blood pressure pills or whatever. Alcohol is a depressant. So there's a lot of medications or substances that work on the brain, but the psychotropics are ordered to help with certain issues that have been identified by the DSM-5. So you may see those. Now that's not the only thing, and normally it kind of goes. You normally want more than one. Usually cognitive behavioral therapy, counseling combined with psychotropic medications are more effective than one or the other. There are some new things like eye movement desensitization and reprocessing. They do that a lot for post-traumatic stress. Electroconvulsive therapy, the old shock therapy of old, has come back into vogue. And it's used for like severe depressions. I've actually been reading a lot of literature on like psychedelics in post-traumatic stress and long-term depression, which is really fascinating. That's kind of like cutting edge. It's the new buzz thing. Other therapies, art therapy, movement therapy, breath work, and music therapy. I just saw a beautiful video on an Alzheimer's patient who used to be a ballerina and didn't know anything about her life. But when they played Swan Lake, she began, because of her rote memory, to recreate the moves, and it was just beautiful. So you can reach someone's soul or connect with them in ways other than words. And you can do it through art, you can do it through music, you can do it through a lot of different ways. And so when they have those groups for people and Mrs. Lilly doesn't want to go, those groups where they bring people in and they do art, or they might, have a singing or song or some kind of comedy show, that really builds camaraderie. It activates the brain cells. It builds recognition, and there's just a resonance in the person, maybe jog their memory a little bit. So it's just not wheeling them down to listen to, somebody do like a picture show of their trip to Nepal. It really is designed to provide like a multi-sensory experience for this individual to enrich their lives. So when you can get them down to some type of activity, it may seem lame to you, but it might be the difference between a good day and a bad day for that person. So the type of diagnosis dictates the therapy. Remember, we have psychotropics, cognitive behavioral, all kinds of different things that we can do. Movement therapy is very, very good. You can have diet therapy. Sometimes with Alzheimer's, some people want, more of a Mediterranean diet, vitamin therapy. I work with autistic kids. We have children in that Arizona State University study with the vitamins and the diet. It's intriguing and compelling to see lots of different things are being tried to improve all kinds of mental cognition and mental health issues. So depressed patients may benefit from antidepressants and cognitive therapy. Anxious patients may benefit from biofeedback, deep breathing, structured routine, as well as anti-anxiety medications. They also maybe would, like your diet, you have macronutrients. Everybody knows what protein, I have to think, carbohydrates and fat. Everybody knows those, but the micronutrients, like do they, support dopamine? Like a lot of your neurotransmitters are manufactured in the gut. You're always hearing about the mind-gut connection. So somebody who has bad digestion or taking a lot of antacids, not being able to digest their food very well, that may impact their cognition and their production of neurotransmitters. So what the care that you take to optimize all things for your patients can really optimize their lives in ways that you may never know. All you need to know is this person's environment enriched in a way that serves them? You don't want to take somebody who's anxious to the band festival. It might be too overstimulating. But if you knew your patient and you know their patterns, that you would pick those things and you would engage them in their care, say, hey, would you like this? And you would watch them. Did they respond? Did they do a good job? Did they enjoy it? Did it appear to be soothing to them? Did it appear to be aggravating to them? Know your patients. So also, when we're talking about, like, I always talk about the individual therapist or home health aide or nurse as a healing environment. I consider myself a healing environment. So when I am interacting with a patient or another human being, I am watching them and I am trying to use mirror technique and therapeutic communication. I am trying to connect with them in a way that fits their cultural, religious, spiritual, whatever needs, to provide great care. So I have to always check myself at the door mentally. Like if I'm like there's always somebody on the unit that is the girl with the hair on fire. Like no matter what, you're like, that energy is coming. You're like, oh, no. And you know that there's something catastrophic. Someone didn't fill the water jugs, the medications, the pharmacist isn't doing this, the car broke down, there's snow on the ground, it's hot in Florida. There's always something. And you just want to make sure that you're not that person, because that really causes distress to your coworkers, distress to your patients. And so you try not to be that person. And if you have to be that person, you're not that person very often. So you are a healing environment. So you really need to be. And when I say healing environment, we talk about like perfumes. Like people, like a dementia patient may recognize a perfume or be aggravated by a perfume, a strong scent, or so you try to be as neutral as you can. As moderate in tone and as you can with the patients until you get to know them. And because it's their living situation, you're a guest there. You are a guest there. So it's your job to do the work to belong more than them, really. You need to adapt to them. They don't need to adapt to you. This is where they live. So the environment or milieu is a therapy. You are a part of the milieu. You are a healing environment. So is the milieu. So is the environment. So something that is cluttered, dirty, filthy, stinky, chaotic, loud, radios blaring, music that no one likes, that is probably going to aggravate some people. So you're always aware, is this environment, and even like the structure of the schedule, like you don't think about switching around the schedule because you're like, oh man, I want to go on my break and I have to do this course, but I'm just going to switch it. Like to you, that's nothing. Like I'm just switching it from 11 to 12. But to them, to somebody who is forgetful, for somebody who is addicted to their schedule, for someone who is very, very super anxious and doesn't like change, that could be catastrophic. So that could totally change the healing environment. Sometimes you have to change things, but with the change, you must be aware. You must be aware of how your change is going to impact these people's lives. So when the staff are trained, and you know a little bit about depression, anxiety, schizophrenia, dementia, and all the other things, that you know that mental illness isn't always diagnosed, that it could be undertreated or overtreated. The person could need more medication or less medication. They could be experiencing side effects. They could be having delirium from medications. They could have a medical comorbidity like a UTI, or they're dehydrated, or a heart condition that's causing them more confusion or more aggravation. You might have an anxious patient who just drank a pot of coffee at the Starbucks because their granddaughter came and they're off the wall. So you have to think about, you're thinking, your brain's all the time thinking, okay, here's my normal patterns. I know my patient, what has changed, this is different, this is not good. So you know that. Your healing environment, you know your language and your biases, you know, what the unit is like when it is stable and fluid and solid for these people, and you know when chaos enters the door. You're careful not to be the girl with the hair on fire, and you always try to educate yourself and learn. Who can teach you best about how they are? The patient. Doesn't matter what the label is. The label is like a condiment, but the person is the main thing that you deal with. The label helps. A label, when we give labels to people, they're not meant to label people. They're meant to give us guidance. They're roadmaps to treatment. That's what a label is. That's what it's designed to do. So if I have a bipolar diagnosis, that is meant to help me learn about my illness, learn to put it in some kind of framework that I can understand it and seek the best treatment. It is not to explain away bad behavior or judgments of others. So, so we've got some resources that you can go through. I tried to get some evidence-based resources for you. And we also have just a couple questions to see that you can go through on your own. I have the answers right there. But see if you really can figure out. They're just kind of, my questions are really more like memory joggers. And at the end of this, I would like for you to know that some of the best people in the world have mental health diagnoses, and probably we all have them or should have them every once in a while, and maybe all the time. But when we enter into a system where we are lucky enough to work with other human beings and impact change, then it's our job. It's our job to know people's diagnoses, not to define them or judge them, but to know how they best thrive, and what their patterns are when they're at their best, so we can recognize what happens when they are not at their best and how we can optimize ourselves as a healing environment, the treatment they receive for their mental health diagnosis, and the therapeutic milieu, which is the environment, how we can optimize that so people can thrive. So hopefully you learned something, and I only went over 2 minutes, and I'll see you on the next one. So.